Okay, do you see my screen,
So,
Stefano, by the way?
I see your screen. I see your screen.
Great. Okay, so let's get going. So welcome everybody to Vision Virtual Meetup. Welcome our guests from the Bay Area who probably experience very much what we've just been discussing as well, and welcome people from all over the country and all over the world. Today, I'm very happy to host Dr. Stefano Bini, Professor of Orthopedic Surgery at UCSF and the Chief Technology Officer of the Department of Orthopedics at UCSF. He'll be talking about digital orthopedics, the rise of specialty focus. Before we get started, just a few minutes about us, RSIP Vision. For those of you who don't know us already, I see it's nice to see many familiar names in the attendee list as well as many new names. So we are RSIP Vision. We are a solutions provider. We provide AI R&D services for solving computer vision problems for medical imaging. We're a large interdisciplinary team of mathematicians, computer scientists, physicists, MDs, and medical annotation specialists. And we've been doing this for many years, and we'll be happy to talk to you about your application. As a company that's focused on image processing and computer vision and solving these problems, we work across many multiple medical modalities and medical applications, from cardiology, pulmonology, to orthopedics, ophthalmology, surgical video, and more. Over the many years we've been in the market, we have worked with almost any medical imaging modality you can think of. And actually, orthopedics is one of our strongest areas of focus. It might be, I might say, even the strongest in this space. We're offering capabilities from 2D and 3D image segmentation, mostly for surgical planning and navigation applications, landmark detection in X-rays and in 3D imaging, again, mostly for surgical planning, but there are other applications as well. 2D to 3D reconstruction from two-dimensional projections, reconstructing full 3D models of the bone, and various registration and surgical navigation applications as well. So without further ado, I will pass on the screen to Dr. Bini, who will share his talk. Stefano, I'm very much looking forward to your talk. I see that you're quite active in sort of the intersection between digital health and orthopedics. So very happy and very excited to be hearing about this space.
Terrific. So I'll be happy to do that. So I am now going to show you my slide deck, and hopefully that will come up presently on our screen. So that's great, except I lost, there it is. Okay, so very excited to be here. My name is Stefano Bini. I am a professor of orthopedic surgery at UCSF, where I also serve as the orthopedic lead for the digital health innovation team. But my role, an interesting role I have, is that of Chief Technology Officer for the department itself. And I argue that at the end of the day, in this world, the Chief Innovation Officer for an entire hospital system isn't going to be able to foresee the needs of a specialty service, and that our needs, even within orthopedics, varies from, say, pediatrics to geriatrics. And so as a result, we really need to have a new set of people leading the charge on deploying and implementing the technologies that are going to make us more effective in the future. And I also work with the American Association of Hip and Knee Surgeons, and I found a conference I'll tell you about towards the end. So moving on to the next slide, these are my conflicts of interest. I do advise some companies. So let me make some definitions first. Digital health is the way we deliver care. It is not the care we deliver. So it's an important distinction in terms of when you're trying to get your head around what problems we're trying to solve. And we're trying to solve problems that are looking at the system, the delivery model, how we optimize resources we currently have, how do we improve the overall quality of outcome at a system level, and identifying those solutions that can solve those problems that maybe currently we have an analog solution for, but in reality we could do a better, more efficient, less costly job with using digital solutions. We'll talk some about what that looks like. Now, in the bigger picture of digital health, this group of technologies that help us improve the way we deliver care, there's been a massive uptick in the investment community. And this is a slide I borrowed from Startup Health. And you can see the really significant increase. I mean, it's a massive increase over the last 20 years. And you see that as of June 30th, just a couple of months ago, 2020, we're already planning to exceed the previous investments. And that money will go to some way. Our lives will change as a result of that. So what are the funding areas that are being addressed? Mostly access to care, which actually impacts orthopedics with telehealth and teletherapy and that kind of thing, but also areas where we lower costs, and also obviously the next big one is cancer. Patient engagement and patient empowerment type platforms have received a lot of the funding. Clinical workflow, though, is interesting because most people don't realize how important that is to the administration and to the delivery of care models, and a lot of money has gone into that, but also biometric data, which in our world is sensors, and use of sensors to drive innovation. So we're definitely seeing a move in terms of the funds that are going into orthopedics into areas that are eminently applicable to the work that we do. I apologize. I also want to give you a sense of how much money we're talking about here. So look at Grail. It's a biometric data acquisition company. Yes, they're in oncology, but $390 million in a Series D fund. They're a wellness pharmacy. Alto, actually, we work with. It's a delivery pharmacy that actually delivers medications to patients and doesn't have the overhead cost of having brick and mortar stores, and Oscar, of course, the insurance company. So it's really things that are going to change the way we deliver care are being funded heavily. So now moving down into the area of digital orthopedics, what is digital orthopedics? A lot of people ask me that question, so I came up with a definition. I think I even tried to put this in Wikipedia, Moshe, but I don't think it actually got up there. The application of digital technology and data-driven analytics to optimize the practice of orthopedics and the personalized management of musculoskeletal patients. I think personalization of care is where a lot of these technologies will allow us to go. Now, what is the bucket? What are the technologies that we're looking at? And if you look at this list, 3D printing, big data, sensors, it looks relatively familiar if you're in the digital health space. Like, why is this necessarily an orthopedic thing? It isn't. It's just like the combustion engine, when invented, is a technology. It can be used in a tractor or it can be used in a race car. The technology is foundational. How you then use it is what we're talking about when we get to digital orthopedics. So if you take these technologies and you move them into the use cases, now you get into image analysis. It's AI, but the way we use it is image analysis, right? RFID technology and machine learning can be applied to resource allocation, workflow optimization, and what have you. So all these technologies that I previously shown on this slide can be applied to MSK, and the interest to us is how do we get the technologies that are currently available, find the use case within orthopedics, and implement them to the benefit of our patients. So there's a difference between a problem and a pain point. A problem is something that we all recognize and we all have in our lives. It could be a leaky roof, it could be an oil change that needs to be done. The truth is you don't get to it until it becomes a pain point. So what I've learned in a decade or so of deploying technology is if you're going to try to implement some technology within orthopedics, you have to solve a pain point, not just a problem. So what are classic pain points that perhaps are not so obvious to the individuals? I'm going to mention a couple of these and I'll show you how I'm actually going to solve them, or am solving them within our own department, to give you a sense of how digital technologies and digital innovation is going to support digital orthopedics. Referral management. It turns out that something like 30% to 40% of all referrals that are sent to an orthopedic clinic, in fact, for any specialty clinic, never actually turn into appointments. And that has to do with the friction involved with actually reaching the clinics. And there are software platforms now that can decrease that to less than 5%. Space utilization is another issue. You may have a clinic that if you walk around, sometimes those rooms are empty. Sometimes they're empty because there wasn't enough patients to see them, but sometimes it's just bad scheduling. Or you may be behind 45 minutes in your clinic because there's too many people who require an x-ray that was scheduled. This is a solution that be addressed with artificial intelligence. EMR data entry. You hear a lot about the challenges with the interface now, the computers requiring people to spend too much time. Is there a way to automate that so that's simpler? So we'll go through some of these next. So this is a challenge that we have, which is when you have a patient going through a complex procedure like joint replacement, they have a million questions and they have to be many of them have to have a lot of touch points with the clinic that don't really go through the surgeon, to go through our staff. And those touch points are expensive. And so several years ago, a lot of patient engagement platforms came out, which engaged the patient from before surgery to say a month after surgery. There's one that we use, it's now called Get Well Loop, but the interface is the same. I haven't changed the slide. But Get Well Loop is a company that we have used to interface with our patients with great success. The patients love it. Next question, though, is how much work does it do? And we've looked at it, actually about to publish a paper on it, looking at the amount of, it actually increased the number of touch points, but virtual. So for us, less expensive, but it's still about 4,000 to 5,000 new incoming messages to the clinic every year that have to be addressed. So the next stage in this will probably be something like chatbots that have NLP behind them that are able to answer the questions and decrease the overall workflow while still connecting with the patient and answering their questions. This is Robin. It's one of the Suki's, another company in the space that does virtual scribing. That actually the technology is getting good enough that this device or device like it can literally sit in a conversation and from the conversation generate a really powerful clinical note that's pretty darn accurate. They're getting to the point now with the transcription process around 85% accurate. They're only going to get better with time. And again, this relieves the workflow, takes workflow off. And as you get the next generation of these technologies, we'll be able to support the clinician in their diagnostics and also coding, but also something around the ability to come up with solutions that maybe they hadn't thought of, because the software says, hey, given these three things that we picked up on the chart and you note, it looks like this person has this disease. Have you thought about it? Referral management I talked about earlier. There's a company that we work with, Luma Health. They work primarily on the SMS side, so no tablets, and we just looked at our own data from using this platform. They essentially saved us 4,000 phone calls in 3 months, which is a remarkable way to connect with patients using text technology, allowing them to schedule their own appointments, reschedule, and also we saw a massive increase in utilization of our space. So these are the types of technologies I'm referring to when I'm saying we're going to optimize resource allocation. Another one is this one, which is a surgical scheduling platform. It's a company that has really focused on optimizing the use of our surgical resources by providing insight across, for example, multiple hospitals that we may work at. The software talks to itself, but where it becomes really interesting is the AI behind it that reads the chart and is able to identify patients who are ready for surgery if we have a cancellation or we have an optimal or an open space, and allow us also to give feedback to the surgeons about the utilization of the resource. We can reallocate given time that may not be utilized. So using these tools, again, to optimize the way we work, the way we deliver the care. So this is just I think it was 5 examples of how we solve the true pain point for us, because managing surgical cancellations is a pain point. It costs us a tremendous amount of time and effort to get a patient scheduled for surgery. When they cancel, it's a big deal. And then filling that slot again takes, if not days, hours of work. So these are just sort of give you a sense of where we're going. Now I want to shift gear a little bit, because at this point, some of you may be asking yourselves, well, when is the right time to develop a technology? When is there that time to deploy a technology? Because this all sounds really exciting, but frankly, I want to wait for the next gen because I know it's going to come, et cetera, et cetera. So I want to bring up this concept of the adjacent possible. Not my idea. It came from Stephen Johnson in 2011 in a book called Where Good Ideas Come From, and he himself borrowed it from evolutionary biology. And the idea is that innovation usually happens in the realm of the adjacencies around that innovation. There are possibilities available at any given moment. By that I mean that if a great idea comes to you, but there are the adjacent technologies aren't available to implement it, it's doomed to short-term failure. eBay, you could have thought of that idea back in the 1980s, soon after the World Wide Web was invented. But if you don't have online banking, if you don't have the ability to post a photo or an image very quickly from an iPhone, if you don't have the access to servers across the world that can track payments, that simply won't work. So the concept could be there, but you can't implement it. So when you're looking at technology, understand if the adjacencies in the contextual or in your contextual environment, doesn't have to be in China or in London or whatever, in your contextual environment, are they available? to be so that the technology deploying is going to be effective. So let's look at AI as an example. This is Moore's law. It's the number of transistors on integrated circuit chips from 1917 to 2016. As you can see, that's a logarithmic curve. We're talking about 10 billion circuit but the technology, the power to do machine learning was already present sometime in the late 90s, early 2000s. But it wasn't that we weren't doing AI, or at least machine learning that much, right? Why is that? Because it wasn't just a matter of computational power, it was a matter of cost. That computational power was accessible, but very, very expensive. There's a similar logarithmic curve, though, showing the drop in cost. So the drop in cost was very quick, and we got to the point where we're having the famous stories about the best computational power of the United States military is now available on your iPhone. That's true. So the cost came down, the power came down, and that still made it available at early 2000s. So why do we still not have AI machine learning in healthcare? And that had to do with the fact that we just simply didn't have the data. So at the end of the day, in order to see the onset or the arrival of these technologies, which have been around in other disciplines, in other areas of the economy, to healthcare, it wasn't a matter of computational power, it wasn't a matter of cost, it was a matter of having the data available with which to run these algorithms. So at the end of the day, when you're looking at when do I deploy these technologies in the context of AI machine learning, and now is about the right time because all the adjacencies are there. And the last adjacency I'd mention is one that I think I may have introduced conceptually, not a big deal, but it is social adjacencies. The social adjacencies are parallel to technological adjacencies. When you have, when you deploy technology in a context where the people you're asking to implement this technology have no clue how to use it, it's not going to be as an easy sell as if you're implementing in a context of people who already know how to use it, or correct workflows. So that's very important as well, because there's a famous study that looked at the amount, who was able to do digital innovation successfully. And it was those companies whose budget for the technology included a specific budget for socializing the technology and implementation, which is equal to 40% of the total budget for that particular innovation project. So if you're trying to deploy a new gaming technology for gamers, you don't need 40%. But if you try to develop a gaming technology platform in the context of the retirement community, that number may go up to 80 or 90% of your total cost is going to be in implementing technology. So social adjacencies, technological adjacencies, understand them when you start to look at deploying technologies to support your efforts. That said, the possible within these technologies changes daily. Understand that transmission of data speeds is expected to go up 60 times over the next 5 years. The computational power may go up 60x within the next decade. You're looking at energy as one of the fundamental and principal limitations of computation today, but you're looking at technologies that I've seen at presentations to VCs and the like that may decrease the need for energy use by 90%. You're looking at the use of transistors that act like neurons. That means that for robotics, for example, you do not have to access the CPU to trigger a response. That would massively decrease the need for energy. Voice recognition doesn't require voice is coming. Brain to machine interfaces, of course, are coming. And biologically and 3D printing would change everything sooner or later, right? So the possible changes daily, and so what you can dream of doing is going to come into your context very quickly. Let's look at some of these forward-thinking ideas. This is augmented reality in orthopedics. For those of you who are orthopedic surgeons, the idea of basically having X-ray vision, which may have been the fodder of comic books 20 years ago, now is reality. And because bones don't wiggle around in space like the liver or the belly, we can actually know exactly what that bone's going to be. And companies like RSIP Vision can give you tools which you can actually do your surgery ahead of time, reposition all the fracture components so you know what you have to do before you get in there and recognize the time off. This is no longer science fiction. This is a reality that's coming. Using machine learning, convolutional neural networks, something that, again, RSIP Vision does extremely well, is the ability to know exactly where a specific part of a bone is in space, even if you can't see it, simply by morphing either from a CT scan or a number of previously obtained CT scans, a likely shape to it, to within a 0.5 millimeter or so, is no longer science fiction. So we can do blind surgery without actually ever exposing the bone, but being very, very accurate. And this is already being done in the spine. Virtual reality, augmented reality, there's a company in Australia that's already reaching patients in the outback using Microsoft HoloLens and supporting a nurse. This is a bit of a dramatization, frankly. Doesn't quite work like this, but it's pretty darn close. And the idea that you can have a very human experience, it's not this random experience with some kind of a strange looking avatar that may or may not look like you. We're talking about actually projecting a real human being into your visual space. When we get to retinal projection and these headsets go away, we get into some really interesting stuff. So with that, I want to go to Q&A. Thank you, Moshe, for letting me tell a little bit about this event that we run. It's called Digital Orthopedics Conference San Francisco, DOCSPERA. We've been running this for now for 4 years, and we tackle exactly these questions, how to implement technology in healthcare, specifically with orthopedics. And if you go to our website, you can sign up, and we'll let you know what we're doing. This is a pictogram of the who we had visiting us on the last conference. We did this over quite a number of participants, a worldwide audience that really tried to drive the needle forward in the space. With that, I want to thank you. Certainly follow me on LinkedIn. I post a lot there and I have a few opinion pieces. And I'll turn this back to you, I think, Moshe.
Just a moment.
I was muted. Yeah, thank you very much, Stefano. So I got a bunch of questions. I just want to remind the audience, feel free to type in your questions as well, and I'll transmit some of them. So I'll start with one or two of mine. Going back to the topic of patient engagement you were talking about at the beginning of the talk. What do you find is most interesting for the patients? What type of questions are they asking, and is there a visual aspect to that? Are patients interested in sort of understanding visually their anatomy and how the surgery is going to be performed, or what do you find the most sort of in-demand things from the patient's perspective?
Yeah, what's the value prop, right? To the patient, not to me. Yeah, look, it's hilarious. It's interesting you should ask. I had a 77-year-old patient of mine yesterday in the clinic, and she actually, I almost, stop, let me just videotape you, because she was so eloquent about it. And she said, look, I knew perfectly well that it wasn't you sending me those messages every day, but it was your signature on them, and I have never felt as cared for, as safe in my perioperative recovery process as I have as a result of being engaged with this technology. I felt connected to the clinic, because one of the things we published was that the average time to answering a question was 1 hour, as opposed to 1.5 days when they leave a voice message on our answering machine. So the patient being able to feel connected to our staff in a way that they couldn't before was a very, very major value prop. This is usually, surgery is a scary thing for most people, as frankly it should be. And so they go into it with trepidation. The fact that they don't have to rely on sisters, brothers, husbands, and wives to support the recovery, that they feel like they got a partner elsewhere is a very useful tool. Contextually to that, we can add visuals, as you mentioned, and we can add physical therapy, but the real kernel of it is the idea of feeling safe and connected to their practice, to my practice.
Okay, thanks. Yeah, so you're saying even if they know that maybe a chatbot is answering, that's still valuable? They still feel that they're getting some kind of response.
Yeah, it's my chatbot.
Yeah, and I'm sure the platform also makes it much easier for the surgeon to answer them personally, just much more efficiently.
So, it's interesting. We have so many assumptions around technology that we always have to challenge. So let me give an example around that specific one. It turned out that in my department, the 3 highest users, one of them answered every question. One deferred to the PA half the time, and one never bothered to download the app to their own phone, so they never ever even saw the questions. All right. So I was pretty confident that I would see some variation in the satisfaction scores, because we ask all these people what this, it's like we're an academic program, so we're tracking everything. And my assumption was that that would be a thing. And of course, the way I framed it, you can guess at the answer. There was no difference in patient satisfaction or perception of care in the context of this particular platform around joint replacement, whatever. But I was surprised. I was genuinely surprised. We have a lot of assumptions. I'll give you another example that we're looking at right now. So COVID hits, and prior to COVID, in the United States, the adoption of virtual telemedicine tools was very low, particularly in orthopedics. It was less than 2%. Then very quickly, we switched to somewhere in the neighborhood of 100% to 80%, depending on the facility. And then the assumption of those of us who are in this space who have been promoting and pushing virtual visits, because you don't have to drive in for hours to see your doctor, you have to sit in the clinic and wait to be seen, you're not going to be late, you don't have a half day off, whatever, that there'll be massive uptake. Well, guess what? It turns out we're back to around 5 to 10%. Now it's maybe double what it was before, but we're not talking about this massive adoption. Patients are actively choosing to come in to the hospital, to the clinic to see the doctor, even when offered a telehealth visit. So there's two ways to read that. If you look at the adoption of many other technologies in the past, it was slow and arduous. We were not all doing online banking the minute it was made available. And I think some of the smart people I've talked to have said, the thing is, we just haven't nailed it yet. The experience today is still clunky. The experience doesn't feel like you really saw a doctor. They can't lay hands on you and what have you. And he says it's the experience that has to improve before we can get wider adoption. And others just say, no, look, the human interface simply is not touching those dopamine receptors until you just need to, we're not gonna be able to get rid of the human experience yet. So, and the last piece could be this is generational. The current 20-year-olds are not seeking orthopedic care. So maybe that's the issue. We don't have a generation that is digital first coming through the orthopedic clinic as a rule. So those are three ways to explain that. But I think we should always challenge the assumptions that things that we think people want, actually they want.
Do you think there's a significant difference between orthopedics and other areas of medicine in terms of the readiness of patients to adopt telehealth?
Yes. So what we're seeing is that in the chronic care pathways where people were coming in once a week, if you provide them with the necessary Wi-Fi enabled tools, take the blood pressure, to take the heart rate, to transmit the sugar levels, that they may have done a pinprick, but it's automatically generated and sent to the clinic, that in those practices where you're dealing with a number of visits that are really check-ins, for those check-ins, virtual health is really doing quite well. And the other area where it's working very well, the other place working very well is the one-off. The mom with a kid that hurt themselves playing soccer goes online, gets an immediate virtual visit with a pediatrician or a pediatric orthopedic surgeon if necessary, and even pays out of pocket for that access. And we're seeing that play out quite well with several companies. So there, it's not, but what's interesting to me is that we tend to take these very broad brush strokes to healthcare and assume that because it works in one area, it will work everywhere. And then you see these companies come up with these business models that include the 360 million, 320 million people in the United States as potential customers. No, it just doesn't work that way. For each solution, you're solving a pain point that's very specific to a population, a subpopulation, if that makes sense.
Mm-hmm. Yes. Question from Mark. As you mentioned, innovation usually happens in the realm of the adjacent possible. However, in light of the pace of increasing compute power, data, and AI capabilities, do you see a dichotomy between adjacent possible or incremental innovation and long-term innovations and moonshots, or is that becoming more of a continuum these days?
Well, I think it was always a continuum, and it's time-dependent continuum. And just for the interest of time, I pulled out the famous slide about the speed of innovation adoption from the early Neolithic times to today, and it's a vertical line in the context of history. And so you can certainly argue that you can't look backwards in terms of understanding the rate of innovation. You have to look forward. So your point's very well taken. My last slide, the fourth slide in that sequence that I pointed out that the possible is changing on a daily basis was intended to answer that very same question, Mark, because I totally agree with you. But, which is why I put in, or I surface this concept of the social adjacencies, because those are much, much slower to change. And whether it's a legal network framework or the ability of humans to accept and implement innovation across a population, not the few people at the top like yourself that are really thinking about this, is that may wind up being the rate limiting step, not the computing power of a platform, not the data available. So yes, and.
Very interesting. Yeah. So we've got exponential, increase of capacity on the technological side, or at least on the hardware side. But that doesn't mean that the social side is going to move forward at that pace, and that's just as important, if not even more important. Okay. Moving on to a question in a different realm. Question from Tom: how is 3D bioprinting impacting orthopedics today? I just heard Dean Kamen this week talk about a project where they recently bioprinted a viable 7-centimeter long bone with ligaments. So 3D bioprinting, how far along do you see that these days?
So I think that's an adjacencies issues. I think it's definitely moving forward. But let's take that example, for example. Yes, it may be viable from a biologic perspective. In other words, that bone may actually have living cells that in the right context continue to be alive and receive the appropriate nutrients. But in terms of structural integrity, before you can put that bone in a body and have it accept normal physiologic loads and actually not fracture or break, we're kind of a ways away from that. There are going to be bioprinting solutions out there which are going to be quite good. Then the question is, fine, let's just assume that we're looking at a 5-year time frame. One of the problems you're looking at in healthcare when you start looking at marketing and selling a product is that the entire ecosystem is using up 1/8 of the US GDP. And there are a lot of forces at play trying to decrease that. So you're not looking at a market that's willing to spend more for something they can do with a allograft or a metal device like a knee replacement. So I am always asked the question, okay, even that's really cool stuff, where's the business model to support the very high cost of actual implementation? So I think that the social adjacencies in some of these biologics are and within social adjacencies, I mean legal framework, I mean monetization framework that exists in our current society. Those are all part of what I call the social adjacencies. Are yet to be fully defined for some of these very forward-thinking and extremely cool technologies. That said, what's going to happen is they will find limited solutions, which could be a specific ligament graft that is hard to replicate, like the ACL. Right now, we have a we use these linear ropes basically, and the ACL is actually a fan. So if you create a 3D fan that looks like a real ACL that could have been bioprinted based on the patient's native anatomy and the opposite knee, that kind of stuff, now you start to get into applications that I think, niche applications that I think will see the first implementation of these technologies at scale. So I gave you sort of two sides of that coin. One is for some of this stuff, it's the way they're presenting it's a little bit futuristic, a little sci-fi. And others, I think that, yeah, absolutely. If you find the right niche, the right problem that we haven't quite solved yet, the ACL is an unsolved problem as far as I'm concerned. Yeah.
So it's not enough to do something cool. You really need to prove that it's better than what's already out there. And yeah. in the specific niche. Another question from Steve, also sort of related to this. Can you elaborate on the distinction between pain point versus problem? You mentioned at the beginning of the slideshow.
Yeah, that's a really good question. It's one of my favorite things to just hammer home. I just love the car analogy in orthopedics, but everything seems to be like a car. Some part of a car is orthopedics. So imagine that you have worn tread on your tires. You can probably get along quite a long time without replacing your tires because you just go a little slower, you avoid bumpy roads, you may not overload your car, and you can get by quite a long time. But if you have a flat tire, you really have no choice. You have to fix it. It's a true pain point. So if you bring to a hospital system a solution, let's say they're hemorrhaging somewhere, they're losing money in some area, and you have a solution that with a relatively limited ROI can increase their outcome, not their outcome, their revenue significantly, and avoid that problem. That you solve the pain point. So the ones I showed you earlier are, I think, good examples. If I am missing out on 30% of my appointments, like I get referred 100 patients a month, say, of those 30 I never see, I just never even get a chance to see them, that's a huge hit to my practice, right? So if you have a software platform that by using easily accessible technology that makes it easy for the patient to make an appointment, and now of those 30, I've captured 80%, and it costs me the equivalent of 2 visits of revenue to pay for that resource, the ROI is pretty compelling, right? So some of the AI that's been used in hospitals to optimize the allocation of operating room time costs around $100,000. As a rule, for say a 15-room hospital, they can probably generate $2 to $3 million more revenue each year. You start getting to some pretty compelling numbers. And those are pain points, because that's money left on the table and a hospital is hemorrhaging. If they're flush with cash and everybody's happy the way things are going, probably not a pain point.
They won't bother. Yeah. And last question is actually following up on that from Erasmo. Can you elaborate on robotic surgery as problem versus pain point? So how do you see?
Really good question. Yeah, really good question, right? So it's a pain point, but the person. So here's my take on robotic surgery, and you may have seen my post on this. The value proposition of robotic surgery is in decreasing variability in outcomes, right? So if you look at the costs in healthcare, something like 30% of the costs in healthcare are associated with variations from known best practices. In the context of robotic surgery, particularly in orthopedics, the variation in costs by having implants put in incorrectly is tied to increased pain, longer recovery, dislocations, fractures, etc. And we're now starting to see data showing that if you look at 90-day readmission rates, 90-day global costs of care, patients who were treated with robotic surgery cost on average $2,000 to $3,000, in some papers $5,000 less to the system on the whole, because there are fewer readmissions, less pain, shorter length of stay in the hospital, and less time spent in recovery. And pretty much all the data from the registries today shows that robotic placed components have a longer longevity over a 20-year time frame. They have just fewer revision rates, okay, especially in the unicompartmental knee replacement space, which I know well. So what does that mean? The problem is that those savings do not accrue to the person who paid for the robot. That's one of the huge problems in healthcare. Somebody who pays for a service isn't necessarily the one that captures revenue. The OR has their own budget. If they've got to find a way to pay for $1 million robot, they got to find a way to increase surgical throughput. They got to find some other way to capture revenue out of marketing, whatever, than the fact that the hospital, which is a different budget, just has fewer readmissions, especially in the context of a world where readmission is sometimes actually a revenue generator, right? It's the insurer at the end who really is the one that gains money. So one of the challenges in some of these technologies is that there's disconnect in the healthcare economic model in between who pays for it and who captures the revenue. Another example in my world, very simple, was that when you looked at, I showed you the patient engagement platform. The patient engagement platform I did a paper on this, that decreased readmission rates from 4.5% to 1% to our hospital. So I went to the hospital and said, you guys are the ones that are getting the revenue from this. These are patients in a bundle payment program, so readmission to us is the cost. You really should be covering this cost, and they accepted that model, and they started picking up the cost for orthopedics, because otherwise it was getting to the point where we couldn't justify the cost of the platform, because we couldn't, it was just a straight up cost. There was no revenue benefit other than the patients were happier, which is hard to quantify on a P&L statement.
Yeah. Thanks. So that data you mentioned in robotic surgery sounds really tremendously promising, and thanks for reminding us that it's important for these systems to be organized in a way that aligns the pain points for the patients with the pain points of the rest of the system, so that in the end it's beneficial for everybody. That's definitely a very important part of this. Okay, so I think our time is about up. We got 2 minutes left. I'd like to thank our speaker again, Stefano, very much for taking the time to join us and share his insights. You can reach out to Stefano and myself on LinkedIn, email. My colleagues and I will be at Virtual Meetup in Lima. Well, we'll be virtually this year in 2020. You can read Computer Vision News, which we put out once a month. And let's keep in touch. Thanks, everybody, for attending.
Outstanding. Thank you. Hope you enjoyed that. Thank you. I certainly did. Thanks for questions.
Bye.